A very enlightening talk. So our third speaker for the day is Professor Shahid Javed. Do we have you here, sir? Okay. Professor Shahid Javed served for more than 13 years as the head of Department of Dermatology at Faisalabad Medical University. He has special interest in lasers, dermatosurgery, and contemporary medical teaching, and is actively involved in a lot of researches and academic activities. His topic of today's presentation is high-fluence, low-density fractional CO2 lasers for acne scars. We welcome you here, sir. I think it's going to take 2-3 more minutes, and then he will be able to join us on stage. I would request you all to please remain seated. Thank you, sir. Thank you for joining us today.
My worthy panel of experts, honorable guests, dear colleagues, and the young dermatologists, Assalamu alaikum. In next 10 to 50 minutes, I would like to share with you our experience with treatment of deep scars with targeted CO2 laser. We usually use high fluence and low density fractional CO2 to treat the deep-seated scars. I'm grateful to the organizer of this conference for providing us this opportunity to share our clinical experiences, and especially to the scientific committee and Dr. Sadia for organizing an excellent scientific program. I owe a great depth of gratitude to our great teacher, late Professor, the father of national dermatology, Professor Tai Said Haroun, and the living legend, Dr. Mazurul Hassan. More than 90% of the dermatologists which we see today in our faculty, they are either directly students of these two or indirectly the students of their students. Faisalabad, the Manchester of Pakistan and my home city. And this is the acne, the bread and butter of dermatologists. Although it's a self-remitting disorder in majority of individuals, more than after a span of 10 to 15 years, majority of the patients, they remit spontaneously, but many of these, they have this type of scars, and it's especially embarrassing when they have this type of breast scars like these ones. We can classify or grade scars either depending upon their color or the depth of the lesions, and today we will concern only with these type of depressed scars. These are the ice peaks, box, and rolling scars, and as a dermatologist, you are familiar that these types of scars, they are difficult to treat. You can treat these with topical therapies, and you can treat with these, it's usually spontaneously remitting, self-remitting, but you can treat the keloidal scars with the 5-fluorouracil and a combination of intralesional steroids. But these are the deep scars which are difficult to treat, the rolling scar, the ice peaks, and the box scars, and we will talk our experience with treatment of these scars. The management is slightly difficult since you have to take care of the epidermal and dermal problem, and you can either resort to subcutaneous incision surgery when the scars, they are tethered to the underlying tissue. Punch, excision, grafting, theoretically that seems very fascinating, but the color usually doesn't match on the face. And you can simply use the punch elevation that you excise these depressed scars and elevate the punch, but even then the surface, the epidermis texture, that cannot be treated with these type of procedures. The fillers, obviously either you can use the platelet or the synthetic ones, but again the abnormality of the epidermis, they cannot be treated with these, and if the lesions, they are tethering to the underlying tissue unless you do the subcutaneous incision surgery and combine it with the fillers. The results will not be a good one. Rather, you will end up with donut appearance of these scars. The dermabrasion, the classical dermabrasion in which you ablate the whole of the epidermis and the upper part of the dermis is now outdated. Similar is the conventional laser resurfacing, since the downtime is very prolonged one and it's very risky in our clinically pigmented skin. Nowadays we have the fractional one, and we have two types, the ablative one and the non-ablative. The downtime with non-ablative is minimum, but at the same time the efficacy of these non-ablative lasers, that is also minimum. So we are mainly treating with fractional CO2 lasers, and these lasers, they operate in the range of this wavelength, 10,600 nanometer, and the absorption, the chromophore is the water, and water is present in epidermis and dermis. That's why we can target both the epidermis and the dermis, especially the papillary and the reticular dermis, and you can ablate the column of the skin. The absorption is high, so although there is risk of post-inflammatory pigmentation, but you can ablate the whole columns in a fractional manner. This is the concept of fractional laser, that is you ablate fractional of the epidermis, remaining islands of the skin, they remain intact, and that's why there is rapid re-epithelialization from that remaining skin. And this is the histological picture, that is within 7 to 10 days you get complete re-epithelialization, that is very rapid as compared with the convention one in which you get re-epithelialization after 2 or 3 weeks. This is animation showing you how these types of fractional lasers, that is, they remove part of epidermis and increasing the intensity of laser beam, you can go deep as far as you can. And by this way, you can practically ablate the damaged area, not only the epidermis, but the dermis one. This is a close-up with 19 millijoules, and you can see these white, these are the vaporous central area, but you can see the intervening skin also contracts, and that's the beauty of CO2 laser, that also leads to modification or new collagen formation in the skin, which is not directly targeted. The close-up again in slow motion, and you can see the contracture, the immediate contracture, since the collagen fibers, they are heated up, so the skin becomes tightened, and there is immediate remodeling of the skin. As I said earlier, we can go deep as far as we like to do, and simply by increasing the energy. Currently, majority of dermatologists, they are operating the laser in this range, 25 to 50 millijoules, but we usually go for the highest, since we want to treat the deeper papillary and reticular dermis with the fibers they are damaged, and that's why we are sharing this experience of treating with high intensity, focused or targeted CO2 laser. And this is again a schematic representation that unless you treat the base of these scars, like these ones, the results will not be sufficient ones. You have to have an optimum energy of 150 to 160 millijoules. That is quite a high energy, but in order to avoid these side effects, we decrease the density or the percentage of the body surface area that is being treated with this sort of laser. This study was conducted in a private setup, and after getting the informed consent, inactive, but and the individuals, they were off systemic therapy, but obviously they were applying topical retinoids as maintenance therapy. And individuals with any other concomitant medical illness or disease, they were excluded, and the tendency towards keloid formation and the immunosuppressant, patients taking immunosuppressants, and they were also excluded. Immediately before the therapy, they were given oral antiviral, and antiviral, they were continued for 5 days. We did not use anti-systemic antibiotic, only was applied to the lesions, and they were instructed to avoid undue exposure to sun. Who started after 10 days topical hypopigment agent, or they restarted their routine use of topical retinoids after 2 weeks. We mainly use topical anesthesia, and in some of the individuals, the chilled air cryogen was also employed during the procedure, and these were the parameters we utilized. The laser we used were of Fractional. It's a Korean brand, and it has a pixel size of 100 micron. Energy was tailored depending upon the thickness. In females, because of their thin skin, we usually remain on 130 to 140, but for male, for thick skin, 150 millijoules. And in some of the individuals with thick skin, especially the male patients, we have to have 2 passes, and the coverage was 20 to 25. It's a quite high energy. That's why we focused our laser beam or the scanner only to the area which are involved. This is the picture. You can see the scanner size is usually 3 to 4 millimeter. The individual acne scars, the individual lesions, not the whole area, but the individual lesions there were targeted, and you can see the immediate effacement. Unless you see 70 to 80% of the immediate effacement, like this one, the results, they are not going to be good after the treatment. So you have to tailor the energy depending upon the depth of the scars, and this is what we call it targeted high intensity, high affluence, low intensity laser therapy. And the clinical endpoint was the significant scar effacement. By effacement, we means that this is the pre-treatment and this is immediately after treatment. Unless you get 80 to 90% of the filling of the scars immediately, the long-term result will not be good one. 2 sessions, 6 to 8 weeks apart, and follow-up evaluation was done after 3 months, although it's documented that continuous remodeling continues to occur even after 5 to 6 months of a single session of fractional CO2, but because of the limitation of the study, we kept the 3 months. And the evaluation was on-site clinical assessment on a visual grading scale of 1 to 10. 30 patients were, they were recruited. Majority of them were females, and but unluckily, 40% they did not complete the whole trial, and we can evaluate only 18 patients, that is 60%. And then, after 3 months after the 2 sessions, on average, around about 65% of the improvement was seen. This was the immediate before the treatment. This yellowish or blanching is because of application of topical amla cream. And this is the picture immediately after this session. You can see there is a slight oozing, and this is because the intensity is very high, and that's why the capillaries in the papillodermis, they are also damaged, and you get some oozing, and these are the results after 3 months. Another patient, and this was a comparatively patient with darker skin, and that's why still after 3 months he's having some redness, and this redness is also because of topical use of retinoids, which we, as I said earlier, since majority of the patients, they are using topical retinoids before the treatment as a maintenance therapy for acne, and they restarted the treatment after 2 to 3 weeks. And this is because of that retinoids. But there is usually 50 to 60% improvement in the scar. Another patients, and again, a comparatively 10 patients, and again, the other side of the same patients immediately after the treatment after 3 months. The complication, it's a bit painful since we are using very high energy, 150 millijoules, and again, 2 passes in some of the male patients. So we have to take the help of topical. In addition to topical application of the amla cream, we have to sometime during the therapy use the chilled air to control the pain. Bleeding is the predictable immediate side effect, but the most difficult to educate the patients and to manage is the post-treatment pigmentation. Unless you educate the patient and you yourself understand that this pigmentation is part of the healing process, and it usually takes 4 to 6 weeks, it becomes difficult for the patients to accept this and to treat this. But you have to educate the patient before going for any treatment that their pigmentation will take some time, usually 4 to 6 weeks, and we usually start after the treatment a tailor-made cocktail of glycolic acid, hydroquinone, and we again start using retinoids after 2 weeks. But this pigmentation usually takes around about 5 to 6 weeks to settle down, but the results, they are good. In short, the targeted high fluence, low density fractional CO2 laser is good option, but the patients and the treating physician should understand that post-operative pigmentation is a part of healing process and will usually take 4 to 6 weeks. Thank you. Thank you for your listening. Thank you.
So now that we're done with today's talk, I would like to ask the audience if they have any questions for Dr. Shahid. Any questions so far? Okay.
Thank you, Dr. Shah. It was a very nice presentation, and fractional carbon dioxide is a long-standing, well-recognized treatment for acne scars. Do you have any comparative data comparing this fractional CO2 with PRP microneedling? Because I personally feel that sometimes in our patients, fractional CO2 does cause post-inflammatory hyperpigmentation, whereas PRP microneedling gives good results without any sort of this threatening post-inflammatory hyperpigmentation. And the third thing is that in some stubborn patients, we do combine fractional CO2 with microneedling, either with some kind of mesoserum or maybe PRP. So your experience on that?
As I said earlier, pigmentation, you should understand that it is a part of healing process. Just like bleeding and crusting is inevitable immediately after the therapy, the pigmentation will last for 4 to 6 weeks, and it should be considered as a part of healing process. It's bound to happen in our racially pigmented skin, and it usually settles down in 6 weeks' time. I have not done any comparative trial with the PRP and CO2 because I think the documents and the literature support this. There is no comparison of fractional CO2 with PRP. Fractional CO2 is far better than PRP. It physically ablates the whole of the epidermis, the damaged tissue in which there is texture change. It ablates the whole of the column of epidermis and the dermis. Yes, PRP does give you new collagen formation, but only in the dermis, and you are not removing the damaged textural epidermis and dermis. Unless you remove the damaged tissue, there is obviously microscopic evidence of new collagen formation with PRP, but clinically the effects not. Individuals who are doing PRP, they are familiar that clinically the effects not as rewarding as CO2. There is absolutely no comparison with PRP, absolutely. Yes, you can combine, but even with CO2 alone, there is new collagen formation even after 4 to 6 months of a single session. The new collagen continue to grow even after a single session after 4 to 6 months. It's comparatively easy, and downtime is minimum, but if you are going for low downtime, then you have to resort to non-ablative lasers. Non-ablative lasers, although they are not as effective as ablative CO2, but the downtime is less. In the literature, they usually say that if you do 4 to 5 non-ablative laser sessions, they are comparable to one session of fractional ablative CO2.
Assalamu alaikum. First of all, please be quiet. Achha. Sir, very nice presentation. And there is a new concept that even you have to combine for these types of deep scars. You can combine various treatment modalities like, as Jan Sahab said, PRP or microneedle, and even in newer studies they are combining microneedling with CO2 fractional lasers in deep scars. And in our skin type, there is a huge risk of post-inflammatory hyperpigmentation. And so it's better to use low fluence as well as low density to avoid the post-inflammatory erythema, scarring, and PIH. And another thing is to avoid the complications, especially and specifically PAH. There are new ideas that, as you know, that there are microtunnels immediately after these fractional lasers, especially these CO2 one. So they recommend that you should immediately apply tranexamic acids or vitamin C or HA serums to avoid post-inflammatory hyperpigmentation and to speed up the recovery post-operatively. So I think that most of us who are having fractional CO2 in our clinics and even in the government setups, so I think we should learn from you, and what we can do, that we can add post-operative things like PRP or new serums in form of vitamin C, niacinamide, as well as ferulic acid to enhance the healing and post-operative complications after. Thank you, sir.
Obviously, the combination therapy will be better than the single therapy. The main purpose of sharing this experience was majority of our colleagues, they are using low fluence and low density. And the results, they are not good ones. I have seen patients who have underwent 8 to 10 sessions of CO2 laser with minimum clinical outcome. We have never done more than 2 or 3 sessions. Majority of individuals, they underwent only 2 sessions. Hardly 1 or 2 patients, they needed third session. So the main purpose of sharing this experience was use high fluence, and unless you have an 80 to 90% immediate clinical effacement, your end result will not be going to good. And in order to avoid this side effect, you go for targeted therapy, that instead of treating the whole of the area, you target the individual acne lesion. That obviously will take a little bit more time, operative time, but you can avoid the undamaged skin. And you only keep your scanner to the individual acne scar, but please go for high fluence. I don't want to see any patients who say that I have went 8 to 10 sessions of CO2 laser and still my acne scars, they are not a good one. And majority of patients you have seen, they usually complain of this. Obviously, the post-inflammatory pigmentation is going to be there. And I said earlier at the start of my presentation that post-inflammatory pigmentation should be taken as a part of healing process, and this should be understood by the treating physician and by the patient also. Unless the patient do not understand this, you have to refuse. And as far as the other combination, a majority of the patients, they are using retinoids as a maintenance therapy, and we again start topical retinoids and hypopigmented agents who usually start after reepithelialization after a week, and obviously the still epidermis is thin one, the penetration is going to be high. And one comment about the commonly commercially available serums with vitamin C. May I caution my youngster that being a senior, I know from where they are manufactured and who are the original manufacturer of these. And majority of these, please be cautious. Majority of these, they contain low intensity of topical these steroids. So please keep watch on the skin of your patients to whom you are giving topical steroids. Whenever they come after a month or so, in majority of cases, though, will be able to see thinning of skin and telangiectasia, especially this mushroom growth of topical vitamins. They are manufactured by only 2 factories based in Lahore and with different names. So be cautious.
Is Dr. Abdul Majid Baledai. I belong to rural Sindh and flood affectee. Sir, my question regarding treatment of acne scar. Treatment of acne scar, as you mentioned that laser therapy is the one of the best one. So either even after laser therapy, either chances of recurrences are more or less. And what is the ratio between male and female regarding laser therapy?
So laser is going to do nothing with the acne itself. You have to maintain the maintenance with topical application. Now it's the standard recommendation that even when patients, they are in clinical remission, you continue with topical therapy. In majority of cases, it's a topical retinoids, or you can opt for benzyl peroxide. So laser have nothing to do with acne itself. It's only for treatment of acne scars, the sequelae of acne. And in our practice, if patients, they are not using maintenance therapy, we refuse any laser therapy. Since when you apply topical ointment like Polyfex after laser, there is rebound or relapse of acne, and that is going to happen. So if the individual is not using topical any maintenance therapy, whatever you have applied, simply refuse any laser therapy. And please do not do unless there is clinical remission of acne. And the laser is for treatment of acne scar, not for acne.
Thanks a lot, sir. Sir, my question is regarding...
I'm so sorry. This is the last question we'll be taking because we're running late for the second session.
So my question is regarding the aftercare. You mentioned antivirals that they should be given before the treatment. That they should be given if the patient is giving history of herpes labialis, or it should be given in any case?
Initially, not as a part of study. Initially, we was reluctant to use antiviral, especially in individuals who were not having very extensive acne scar, and they did not need extensive treatment. But one of my patients developed herpes after that. So it's now part of the routine that we start before therapy. 6 hours before laser therapy, we advise them to take antiviral oral, and we continue throughout the healing process. That is usually for 5 to 7 days until their scars.
Topical only, sir? So it should be topical only?
It's oral, not the topical one.
Oral.
We go for topical Polyfex, the oral antivirals.
Okay. Thank you, sir.
Thank you. Thank you very much.